all of you to our discussion. And our discussion today is themed laparoscopic surgery in Uganda, expanding access and improving outcome. And our guest speaker today is Dr. Kiggundu Spire, and is a gynecologist and obstetrician, and also works as a laparoscopic surgeon with Henry Hospital. He's also the acting president of the Association of Laparoscopic Surgeons, and we are graced to have him for a wonderful discussion here. As I earlier on said, laparoscopic surgery has been carried out for decades in the other developed parts of the world, but apparently here in Uganda, due to a number of limitations, it's a comparatively new procedure. And the first laparoscopic surgery was carried out in around 1987. And last month we had a global surgery webinar where we hosted Dr. Jakpreet from Dubai. Dr. Jakpreet is a senior laparoscopic surgeon, and he told us that one of the prerequisites of working as a surgeon in the developed world is laparoscopic surgery. So that further elaborates the importance of this procedure here. So today we have Dr. Spire Kiggundu with us as we explore the extent and the challenges of laparoscopic surgery in Uganda. I would like Dr. Spire to tell us what laparoscopic surgery is, its extent, and the rest of his presentation as we go about the day. Dr. Spire, you're welcome.
Thanks very much, Mr. Kalemba. Can I call you by that name?
Yeah, it's okay, sir.
Okay, I'm glad and excited to be here with you. Thank you very much for the invitation. And an opportunity to talk about Minimaxis for me is a good opportunity. I don't know if I'm audible enough.
Yeah, we can get you to a good extent.
All right. I'm going to share my screen just in a moment. Is it visible for you guys?
Yeah, it is visible.
All right. Yes. Thanks once again for the invitation. Dr. Spire Kiggundu is my name. I'm a gynecologist working with Henry Hospital at Zana. I work as an endopelvic surgeon. I'm also the president of the Association of Laparoscopic Surgeons of Uganda, and I also have particular interest in endometriosis. So today you requested and asked me to talk about the scope, extent of Minimaxis in the country, its challenges, and all that. Maybe I will expect it to be quite interactive at the end. I'll take you through what minimal access is. I'll take you through how far and how much we have achieved as a country. And then at the end, I'll show you a couple of videos of what is possible and what we can do here. First of all, I want to define minimal access. I really wouldn't want to call it laparoscopy per se, because the broader term would be minimal access. The number of synonyms out there, it depends on who you are speaking to. But if you're speaking to a layman, you will call it keyhole surgery. Some people will call it endoscopy. It is widely acceptable. Buttonhole surgery, minimal invasive or minimal access. I really prefer to call it either minimal access or minimal invasive surgery because, as you realize later, it depends on where you're looking. If you're looking in the abdomen, then we'll call it laparoscopy. If you're looking in the thorax, it becomes thoracoscopy. If you're looking in the bladder, it is a cystoscopy. If you're looking in the uterus or uterine cavity, it becomes a hysteroscopy. So it basically depends on where you're looking. And I also mentioned that it is not really much about minimal invasive because the surgery we do in there is sometimes quite much, but the access is minimal. So some scholars would want to call it minimal access surgery. All right. So these are the common procedures that you're going to come across. So if you are looking inside the abdomen, then we say you are dealing with laparoscopy. We use a particular kind of scope or a telescope. Through small punctures on the belly, we touch the abdomen. An abdomen is a potential cavity. We distend it with carbon dioxide. There are many reasons why we use carbon dioxide. First of all, it is cheap. It is less combustible. It is easily diffusible and widely acceptable as a physiological gas. So we use carbon dioxide to distend the abdomen, put in a scope. Then you use small hand instruments to manipulate depending on what kind of surgery you want to do. So that's what you would call laparoscopy. On the other hand, if you're looking inside the uterine cavity, this is what we call a gynecologist telescope inside the uterus. So we look inside the uterus and you'll be able to see several pathologies or the mood of the endometrium, and that's what we call hysteroscopy. So when you're doing laparoscopy, as I mentioned earlier, you will be able to see all the structures of the abdomen, the bladder, the uterus, the liver, the bowel, the urological system. You can touch anywhere, and that is the beauty of laparoscopy. The other thing I want to mention here is that the beauty of laparoscopy is that you do not need many assistants. Especially to give you traction. You don't, need to, mist or missing gauze or swabs or whatever it is. So you have light inside the abdomen, adequate enough for you to see any structure. The cameras are very good and advanced. With technology now, we can use even 4K cameras to give you a very good high definition image, which is 10 times magnified and much better than the human eye. So this is what makes laparoscopy much superior to the human eye as you're doing open surgery. I don't know how many of you on the platform are exposed to minimum access in the universities or your hospitals. But I will try to imagine that I'm speaking to several categories, those who have seen and those who haven't seen. So I'll try to mix, talking from scratch and from basics. Feel free to ask me any question at the end of the presentation. Of course, surgery has evolved over time, just like mankind has, and a lot has changed. So we really want to encourage all the young people to take up technology. It is usually much easier to train a young person to learn these skills of minimal access than to teach an already made open surgeon to convert to minimal access. So we hope that you guys in the audience, I can imagine some of you are still in training. You can really start getting exposure to minimal access because, as you just mentioned earlier, it is the way to go. there are some countries where you really can't practice anymore, including Nairobi here. You will not be able to practice as a surgeon if you can't offer minimum access skills. That is how far the world is moving. Of course, the other world has already been, and laparoscopy has been around for decades. So it is not a new thing we are talking about, really. It's just that as a region of sub-Saharan Africa, we are still lagging behind. But I promise that we are catching up. It's always very good to talk about the history. If we really have to understand the future, we must know our history. So how did it all start? I mean, as you look at these dates, these are significant innovations and significant dates in the history of minimum access. Minimum access started as those are, but been around for quite a long time. And several experiments have, taken place. People have innovated as, as old as the First World War. We've had several innovations. What gas should we use? People started with room air. They, improvised with other gases like helium, argon. They all couldn't work until 1920. Someone came up with carbon dioxide. Ever since it has remained. In 1938, Hungarian cardiothoracic surgeon called Veres developed a spring needle that we use to access the abdomen with minimal risk of trauma. In 1953, Professor Hopkins came up with imaging, and since then the quality of images have really been so good and revolved over time. And it was until in the 1960s when they invented what we call an insufflator. This is a gadget which helps to distend the abdomen for as many hours as you may need to work. Following these innovations, it was clear that the world was ready to attempt the first surgeries. And indeed, in 1983, the first laparoscopic appendectomy was done by a gynecologist. I usually brag to the surgeons that the gynecologists have really put in a lot of effort to innovate, and they have there in history as the first surgeons who did a lap appendectomy, and this was a lap-assisted appendectomy. That means that part of the surgery was done as laparoscopy, and they exteriorized the appendix and were able to complete the excision from from outside. In 1985, the first lap cholecystectomy was attempted, and ever since then, many other surgeries have been done: lap herniorrhaphy, lap hysterectomy in 1989. And in the early 90s, robotics innovation started. So you can see that the world has moved. It has been long since innovation started in this area of surgery, and there is no excuse. I usually tell my trainees that there is no excuse in this era when everything is on the plate for you. There is no excuse why you can't learn these skills. It's many decades later, and it would really be laziness if you cannot take up this. What does the setup look like? You come across what we call a laparoscopic tower, or the minimal access theater. In the minimal access theater, we have a number of gadgets. As you can see, the setting is quite different from that of open surgery, and the theater has to be spacious enough to accommodate the tower. The tower is that cart which has all those gadgets on. We have these instruments I was talking about. We have the insufflator, we have the camera system or the imaging system, we have the energy sources that we use to operate, we have the recorders, you have the light sources. So you must have a full set of these to be able to perform surgery. And anesthesia is usually good enough. You must have a bed which is able to move in different directions, because most of the times these surgeries have a lot of dynamics in terms of patient position. There are many monitors in the theater because the surgeon has to look one side, the assistant looks on the opposite side, and even the runners have their own monitors. So we have a lot of monitors. You can even stream the image to an external audience within or without out of the continent. So this is recorded surgery. It is unlike open surgery. We usually tend to make jokes that when you're operating with minimal access, even a cleaner is able to see that you're struggling or bleeding. Whereas in open surgery, it's just between you and your assistant. Here it is open to everyone to see what you're doing. And the procedures are recorded for the patients, for research, for further editing and viewing. And that is the other beauty about it. It's very difficult for you to be able to record open surgical procedures for even teaching or your own reviews. These are some of the instruments that we use. On the left, we have what we call the trocars. These are the instruments used to access the abdomen and through which we pass the hand instruments. So on your right, you have several types of hand instruments. These are quite long instruments. The difference between open surgery and laparoscopy is that here we use long instruments. So you must learn the technique of converting movements from the short instruments of open surgery to the long instruments of laparoscopy. And this takes quite some time, challenging yourself to understand the depth perception, the high-hand coordination, to try to train your eye to improve on moving away from the two division to the different type of vision. So transmitting movements from short instruments to long instruments is really the challenge of the learning curve of minimal access. But it is doable. It's all about practice, and anyone can be able to do this. All these surgeries can be performed in the abdomen. You can have that range. In the chest, you can do those surgeries. In urology, we can do that range. For the gynecologists, I usually say it is 99%. There is no excuse of opening up someone's abdomen doing surgery in gynecology, except that 1% is usually for the outliers. For example, very large myomas where you cannot place the scope. But 99% is minimal access. In the last 2 or 3 years, I've done very little open surgeries. 99% of my practice has always been minimal access, and this is possible. Surgery can be done in all aspects, in all parts of the body, in the neck, in the axilla. Now we can do axioscopy. Breast implants can be, inserted via minimal access or axioscopy. Spine surgeries are done. Eye surgeries, microsurgeries, ENT, robotics. So when you look at this slide, you will be able to tell that almost everything out there can be attempted via minimal access. Of course, for the gynecologists and the surgeons, who are the majority operators, these are the commonest surgeries that we do. For the surgeons, cholecystectomy, appendectomy, fundoplication are becoming gold standard for minimal access. It is, unlike in open surgery, very difficult for you to now do cholecystectomy as open surgery, the amount of work you need to retract the abdomen and be able to take out the gallbladder is far too much of a punishment than when you use minimal access, as you'll see in some of the illustrative videos. Of course, there's a lot of bariatric surgeries out there now with the increasing rate of obesity. So there's a wide range of surgeries, sleeve gastrectomies that can now be done to reduce on weight gain. As I said, for the gynecologists, yes, it is common that diagnostic laparoscopy is, quite common, tubal ovarian diseases and a number. Hysterectomies are supposed to be done by minimal access, myomectomies, except for the very big ones, and urological surgeries. Of course, to be able to attempt these surgeries, you must know how to suture. That is usually the limiting step. So I usually say there is no future without suturing. So in most of our trainings, we really emphasize teaching our trainees how to suture. You can suture as good as an open surgeon. So this should not be a limitation. It's just about taking time to learn. The question is, what are the advantages of laparoscopy over open surgery? Of course, there are many advantages out there. There are many papers written after following patients in different cohorts for a long time, and you can access many papers talking about the difference between the benefits of minimal access compared to open surgery, and some of these include small incisions of less than 1 centimeter on the abdomen, and that basically will translate to less pain. There is less post-op complications, obviously, because you have better vision, magnified image. You can get into spaces which you wouldn't be able to get into by open surgery. The advantage of carbon dioxide opening up spaces, even in a frozen pelvis. No risk of herniation because you don't have to open the rectus that much. The sky is much more acceptable to the patient. Use on the risk of post-op infection. That basically means that we really rarely use antibiotics. The need for post-op antibiotics has really come down. You don't have to give your patient antibiotics for so many days after minimal access, and that reduces on the burden. I mentioned pain is less, and obviously because of all these I've talked about, the recovery time is less. So when you operate a patient via minimal access, you have less tissue trauma. In open surgery, you have to open the abdominal wall, you have to injure the nerves, you have to cut blood vessels, you have to open the peritoneum, which is sensitive to pain. You have to put in mops, you have to put in retractors. Literally, you damage many cells on your way in and out, and tissue response to trauma is unacceptable. And this is the reason why our patients feel a lot of pain and most of the time, take too much time to recovery, and then return to work becomes a problem. So the reason why we emphasize minimal access is to improve the surgical experience. Surgery should not be a punishment. It should be acceptable to the patient, and the patient should be able to go back to work quickly. And I can tell you that in an event of minimal access, most of the complicated surgeries have now become daycare surgeries. It's possible to do a hysterectomy and release your patient in 6 hours. It's possible to do an ectopic pregnancy surgery, and the patient will go home after 4 hours. Why would you keep them in hospital for those many days? Patients can return to work in less than 2 weeks. So all these are the benefits of minimal access that inform our decision to the transition. As I said, hospital stay is much shorter, 2 to 3 weeks of recovery versus 6 to 8 weeks with open surgery, and basically we have fewer complications. You rarely need transfusion for these patients. You rarely need to use many painkillers, except if you are not a skilled surgeon. You need to train. The learning curve for minimal access is far much longer than with open surgery. And that is why you need dry labs, you need simulators. The country has acquired a number of training centers now. We are proud that several, institutions have dry labs where you have training boxes and simulators. This can help to train the team. The difference between minimal access and open surgery is that here you have to function as a team. It is not about the surgeon. The assistant has to be as good as the surgeon in order to allow you to work. So, all your nurses must know how to handle this equipment. They must know how to retract and assist and suction. So that's why you need the dry lab to have one trained. You need about 20 hours on the box every week if you are going to improve your skills. This is at our center. We offer some training. We have trained over 100 surgeons in the country, and I'm proud to say that this has broadly opened up practice in the country. Of course, so practice is centered in private hospitals in Kampala, but even then that is good enough because right now I can rightly say that ever since we started training 2 years ago, we have over 80 surgeons in Kampala, and most of the missionary hospitals now have towers and they can perform fairly well. Even in government hospitals, we have been able to push the services to Kawempe, to Mulago, Women's Hospital. Now we are proud to mention that these centers can now perform minimal access. Of course, we still have a lot of work to do in terms of advancing to managing complicated cases in some of those places, but yes, at least we have gotten somewhere. So it's really about training. We launched an association in 2021. This was COVID time. You won't be surprised if you see everyone putting the mask. This is the time when we launched the association. It's called ALASU. ALASU stands for Association of Laparoscopic Surgeons of Uganda. This association puts together minimal access practitioners, that the surgeons, the gynecologists, the gastroenterologists, the urologists are all into this association. This is where we sit and exchange ideas and knowledge, grow skills, compare notes, and even regulate practice. Of course, the association was launched by the commissioner and trying to, get government on board to see that they can also appreciate the advantages of minimal access. Well, the association has really improved awareness to the patients and to government officials, because you need government will to be able to fund this practice, especially in public places. We have a collaboration with a number of associations. AWUGU stands for Association of Obstetrician Gynecologists. ASOU is the Association of Surgeons of Uganda. SUGES is the Association of Gastroenterologists, and WUMA. So we try to work together, try and improve advocacy for minimal access in the country, because it really has to be safe for the patient, so there must be someone regulating the practice. Of course, through the association, we have been able to do a number of webinars. Every month we have at least one webinars talking about the different issues in minimum access, and sometimes we invite expatriates from across the world so that they help us to come as close to the other world as possible. So we are moving on, and we've really achieved quite much in a short period of time, because the association has been around for hardly 2 to 3 years. We have been able to conduct a number of surgical camps within the country, and in collaboration with our Kenyan counterparts. So some of these camps have been here in the country, others in Nairobi or Tanzania, and we're trying to work together the region to see if how we can, move minimal access. I mean, we have the same problems in the sub-Saharan region. We have the same gaps of training. We do not have much access to training in public and teaching institutions. You would imagine that most of this should be in the training institutions. If universities come on board, develop curricula where students are exposed, then that would be much better. This is the kind of drive we are trying to put up there. And this is all over East Africa. It's the same challenge, the same problems. So I'll take a few minutes trying to share with you a couple of videos of what has been done here. You will notice that we've really moved a mile, because I can be confident to say that we can now attempt even the advanced surgeries. So medical tourism has kind of reduced ever since we started doing these major surgeries, and the patient confidence has improved. So this video is basically to show you how we conduct training on patients, because it is better to learn anatomy laparoscopically than open surgery. In open surgery, you really don't have much visual access to some of these small structures. It takes the person who dissects the cadaver to be the one to appreciate than the other team. So with minimum access, that is different. Everyone is able to see. You can even teach a crowd of 100 people on one specimen. That is why the world is moving away from open cadaveric surgeries to laparoscopic cadaveric dissections. You can see the anatomy is really very good, much appreciated. You can see the major vasculature, you can see the aorta bifurcating, you see the ureter running down into the pelvis. You are able to see the uterus, the tubes, the ovaries in one exposure. You do not need a lot of, hands in the abdomen. That's the area of the bladder. These areas are impossible for you to access in open surgery. There's no way you look up on the abdominal wall. You can easily open up these spaces. This is, we're trying to demonstrate how you open the spaces in the pelvis and how you track down the major structures of the pelvis, for example, the vasculature and the ureter. Especially, this is quite important for the gynecologists if you're going to perform high-end surgeries. That is the external iliac artery. That's the ureter running down the pelvis, nicely seen. That's the bladder lifted up. So it is would be quite easy to dissect, so as long as you understand the anatomy. Of course, just like any other surgery, anatomy is the gateway. and everyone has to learn anatomy. This is a video trying to demonstrate how to do hysteroscopy. This is inside the uterus. Simple diagnostic hysteroscopy for fertility is much easier than when you would use an HSG. So here you put a scope in, you see the uterus, you can assess the tubes for patency, you can look at the ovaries for evidence of ovulation, you look for any evidence of ailments, and at the same time can treat. This is the beauty of laparoscopy. And then share the video with the patient. We have moved an extra step to provide what you call single incision laparoscopy. Through the umbilical opening, you open a small incision in umbilicus, then you can introduce 2 trocars, and you're able to do surgery. You'll imagine the kind of incision this patient has, less than 5 centimeters, after doing an ectopic surgery. So here I was trying to demonstrate how to do single port salpingectomy. This patient had an ectopic pregnancy. We were able to do surgery on her, and she went home after a few hours of surgery. That is impossible with open surgery. You will need to open the abdomen and predispose your patient to quite a lot of trauma. And, you know, if you're operating on the tube is such a small structure. Why would you want to open someone's abdomen doing procedures on the tube? So it was clear that the patient had a ruptured ectopic, hemodynamically stable, and we were able to, you know, conduct surgery, and she went home quite happy after a few hours. And that is the kind of incision she had at the end of surgery. This is much more cosmetic and acceptable. Here, I want to show you a video of one of the commonest surgeries for the surgeons, and that is laparoscopic appendectomy. If you know, I'm a bit skeptical about open appendectomies anymore, especially if you're dealing with women, because it is clear that 40% of the time, the diagnosis of appendicitis in a woman is wrong, 40% of the time. So if you're going to peep in with a small incision, rather blindly, you're going to miss a lot of pathology. So laparoscopic appendectomy has come a long way to really help us to be able to look into the pelvis, to rule out tubovarian causes, to rule out especially endometriosis. Endometriosis is one of the causes of appendicitis in women, and you know, most of the time it is missed. So you have advantage of looking, you know, bird's eye view of the abdomen doing an appendectomy, and it is rare that you will miss that pathology. You can quickly do an appendectomy in 30 minutes. You know, it's really not that you take more time compared to open surgery. You can do these procedures in even a shorter time because you don't have much of the anterior abdominal wall to close. As I said, suturing and knotting has gotten better, and this can allow us to perform a number of surgeries. All these are surgeries done here in our setting, and all these are possible. So that is appendectomy. You can see how easy it can get. This is one of particularly interesting case. A young man who presented with an undescended testis I think at the age of around 12 years, and you obviously know that if the testis remains intra-abdominal, it has a risk of malignancy. So you would imagine if you had to open this abdomen to search for the testis. You know, the testis is quite close to the inguinal canal, and with the use of minimal access, you can quickly see where it is and be able to take it out without opening the abdomen. This is one of really the advantages of minimal access. So this is an undescended testis, easily taken out by a minimal access. If this patient had a hernia, you can as well fix it on the same occasion without having to put an incision in the groin. I'll talk to you a little bit more about other advanced surgeries. This is a patient who had adenomyosis. You can see the uterus is quite large and bulky. So she had chronic pelvic pain, dysmenorrhea, excessive abnormal uterine bleeding, and infertility. So we managed to debulk the uterus, remove all those chunks of adenomyosis. And as I mentioned earlier, that the skills of suturing have improved quite much, that you can easily suture the uterus and achieve hemostasis in record time. What you can do, open surgery, you can do minimal access, even better. Tiny little instruments inside the abdomen will cause less trauma, less bleeding, and less need of post-op analgesia. The tissues are retrieved by either macellation or we pass them through the vagina. Of course, surgeries as big as nephrectomy in a patient who had suspected, actually confirmed cancer of the kidney. You would imagine doing this surgery open. This would be a nightmare because you have to do this surgery retroperitoneal. You have to put a very large incision in the loin and sometimes extend it all the way to the midline, trying to get enough access to remove a kidney. But with minimal access, with that kind of visibility and distension, you are able to control all the pedicles, achieve hemostasis, have a very good dissection. You can see there is hardly any much bleeding. You lose something like less than 100 mils of blood trying to do this. But if you try to attempt this open surgery, you definitely have to bleed that much. That is the ureter, nicely dissected and ligated. You can see all the major blood vessels below, the renal veins, the renal artery, the inferior vena cava. You can have access to these structures without injuring them and be able to do a meticulous dissection. Remember, you're working close under the liver. So how difficult would this be if you do it open surgery with, the need of all that retraction? The kidney was easily taken out, and thank God this was a lady. So that means you can pass the kidney via the vagina and have very small cosmetic openings on the belly. There is another interesting case here, quite common scenario. This is laparoscopy in pregnancy. This patient was pregnant and had the torsion of an ovarian cyst. So we can as well do laparoscopy in pregnancy, so as long as it is not advanced pregnancy. So you can see that the adnexal, structure is almost black, but when you derotate, it revascularizes, and we are able to do a cystectomy and also placate the ovarian ligament to prevent future torsion. So this is a nicely performed cystectomy to develop the ovary, remove the cystic wall, and eventually closing the ovary with a few stitches. You need to learn how to suture, obviously, because if you can't suture, then you won't be able to attempt these surgeries. Then the ovarian ligament is plicated to prevent any further risk of torsion in future with a nylon non-absorbable suture. So you can see all the surgeries can be attempted. There is no single surgery that can't be attempted by minimal access. This is another common scenario where the patient had a hiatus hernia causing dyspeptic symptoms, and you have to work up there in the upper quadrant, quite close to the major structures, the inferior vena cava. You have to expose the esophagus and be able to put stitches in the hiatus hernia. You can imagine how this would be very difficult if done via open surgery, because you have to make a large incision and retraction is a nightmare. But with minimal access, you are able to do this kind of surgery in less than 1 hour. That is the esophagus, working under the liver, quite close to the diaphragm. So you're able to retract the esophagus, put the stomach on the side, expose the diaphragmatic muscle, and put stitches to close the hiatus hernia so that the stomach will not herniate into the chest. So these are surgeries that are done here in Uganda, and that has informs of the expertise that we have attained. This is another very common surgery for the gynecologist. I mentioned that hysterectomy is a routine case, and I believe that all hysterectomy should do minimal access, because at our center, hysterectomies are done as almost daycare surgeries. You're able to do hysterectomy and allow your patient to go home on the same day or the next day. And these patients are able to return to work much quicker. So this is dealing with the adnexia. This was the in a very large woman who had around 150 kilos. You can imagine opening that belly if you're in hospital for a long time. That's the ureter there, nicely seen, and the visibility is extraordinary. The visibility is extraordinary, and you can be able to move your instruments. You can see that in this patient we lost hardly 50 mils of blood. But with open surgery, definitely the blood loss will be much more significant. So the advent of good energy sources has also helped us quite much. You can be able to achieve hemostasis much better. The dissection is much better with advanced energy sources. And you can see all the bleeders and coagulate them. That is the cervix, taken out nicely. And the vagina. Going down the pelvis in open surgery is a nightmare. Doing these things deep down is not easy, but minimal access makes it look quite easy because you don't need a lot of retraction. The uterus is out, so come through from down, and you can close the vault with a few interrupted stitches. So this hysterectomy in a 150 kilogram woman took us 1 hour. I don't know how much time we would need to do this in the same patient via open surgery. Of course, the large uterus, we're able to macerate it. This is called a macerator. So you shred it into small pieces so that it can come out from small incision. If it was a smaller uterus, we'll be able to just pull it from down and take it through the vagina. This is the kind of woman I'm talking about. You can imagine putting an incision on this belly. You have almost 20 centimeters of abdominal wall. By the time you get down to that pelvis, you really struggle and curse yourself. The risk of infection is high, all the risks of anesthesia, and you don't want to have this kind of abdomen infected. So that is the beauty of laparoscopy, and those are the puncture holes she had on her belly. She was able to go back to work within 2 weeks. Of course, we have been able to cover a lot of ground, a lot of mileage. These are the achievements so far. We now have a registered association for practicing surgeons, and as I mentioned, that was launched 3 years ago. We have trained over 100 surgeons across the country. We now have extensive coverage of minimum access services, both in public and in private hospitals. And we have extended coverage in the rural areas. We have laparoscopy in Masaka, in Barara, in the east, the north. So yeah, we are getting there. We are covering ground. Of course, we would want more than 70% of coverage in the next 10 years. We have convinced more insurance companies to cover minimum access cases. It has been a tug of war to bring insurance on board because of several reasons. One, they believe surgery is a bit expensive. In the initial practice, people are going to get complications, so they tend to get apathy. But at least now, patients can have insurance cover for most of these cases. We have now access to equipment. We have more equipment suppliers, and we have biomedical engineers trained to fix them. Better expertise to handle complex cases. Yes, I would say that at least a number of surgeons are getting better and can handle much more complex cases that we used to refer to Nairobi and India and the rest. So this has really reduced referrals and reduced on the cost involved in that exercise. Patient confidence and satisfaction has improved greatly. Of course, we have a couple of challenges. We have some bottlenecks which impede or run the success. Training is still a challenge. There are a few centers that are training, and this mainly in private practice. People are still looking around for where to get the training. The training is a little more difficult in terms of, and we should see ourselves moving the same way. At the moment, surgery can be by the use of minimal access. The visibility is really superb, and this is one of the benefits. Of course, robotics has improved dexterity. Most of the complex surgeries are now done using robotic surgery. Of course, we do not yet have access to a robot anywhere in sub-Saharan Africa because the robot is quite expensive, but we shall get there. There is what you call transatlantic minimum access surgery. You do not have to hire a surgeon to fly them from one continent to another to do surgery. So as long as you have the robots, the surgeon can sit in their bedroom in California and be able to do surgery in Africa. So that is what robotics have done for you. And the future, I think, is virtual reality. Virtual reality has changed quite much in the modern world, and this is a simulation of how surgery could be done using virtual reality simulation. You really want to avoid this kind of picture. This is a patient who had, I think, more than 6 surgeries trying to sort out a frozen pelvis, just simply because the planning was poor, visibility is poor, and most likely the patient is going to get complication, fistula, and the rest. And coming back to open this abdomen, open surgery would be a nightmare. So if you master the skills of minimal access, you avoid scenarios like this. All right, I think that's what I had for you today. I want to thank you very much for listening. If you have any questions, I'll be more than willing to answer them. Thank you very much, and back to you.
Thank you, Dr. Spire, for that wonderful presentation. We appreciate the different case presentations that you have shown to us. You have talked about the common procedures that are currently the common procedures that can be carried out using laparoscopic surgery. You have talked about the future and maybe the extent. And I would like to have a question about your presentation. And I understand that you say that okay, the limitations, most of the limitations about the access to laparoscopic surgery, most of them are logistic, and then the others are related maybe to training and everything. So I would like to know the role of ALASU and its international partners. What role can they play expanding the access of laparoscopic surgery in Uganda? Because I understand even the machines that are used themselves to carry out the surgery, they are quite expensive, with a single one costing around 1 billion shillings. And by last year, around August, even the National Referral Hospital Mulago had around only 4 of those machines. So I would like to know how ALASU and these international partners, the role they can play in expanding the access and maybe even training of the different laparoscopic surgeons.
Thank you very much for that question, Okello. I've seen you right. Yeah, sure. As you mentioned rightly, the biggest challenge of minimal access all over the world, not just in Uganda, is number one, the skill, getting the skill. It has been quite difficult to train simply because we don't have much access to universities. I personally believe all we are doing should have been for the universities. Because if you put the training in university, first of all, it is longer. Most of these courses are 3 years plus. You have more exposure to patients. But the reason why we haven't had this is because we don't have many skilled surgeons who can train, and those who are skilled are mainly concentrated in private practice. Obviously, because in private practice it is easy for the hospitals to not only purchase the equipment but also maintain the equipment, and also to pay these health workers better. It's been the biggest bottleneck. The purchase of equipment has become much easier. Actually, the cost of equipment has come down. Now we have many more vendors. We have like 3 suppliers now in the country. You can get good towers even at less than 100 million. So government can definitely afford that. But the challenge is, one, maintenance of the equipment, because there's a high turnover of equipment. Training. The will to train is still limited. Most of our seniors are still, into open surgery. Really, a lot of them still have apathy for minimal access, simply because they can't challenge themselves through the learning curve. So that is why I still believe this is for the young people. Young people should take this up, because it is easier to take and train young people before they are kind of taken away by the open surgery route. ALASU, yes, ALASU can only do much. ALASU is a group of about 50 surgeons who came together and thought of having a platform where we can exchange ideas, work together with the medical council to regulate the practice, and also play a role of advocacy. In terms of logistics, ALASU doesn't have any logistics, because ALASU only thrives on the little fees of subscription that is paid. So it cannot meet the cost of training, it cannot meet the cost of logistics. But what we can do is mainly to put together our efforts to see how we can train a few people here and there, with the belief that they can also train others. We, apart from the equipment suppliers and the drug supplier, we don't have a lot of collaboration. Our collaboration with government is still very meager. Government is also still struggling with maternal mortality and basic things. So they still don't believe that minimal access should be on the top of their priority. And this is what we're trying to break through to them, that minimal access actually comes to reduce on the costs of surgery. Because if the patient can stay in hospital for 1 day, then your logistics will go down. The international partners are mainly our colleagues from Nairobi, Tanzania, from Europe. Most of these are expatriates. We call in once in a while to come and help us, but we don't have resources to put into this. That is the biggest obstacle. So I still go down to the fact that if we have to have any meaningful transition, we must bring government on board, we must bring universities on board, because they can train far more people than we can do individually. I hope I answered your question.
Thank you for that wonderful insight. Um, for record, this meeting is being recorded and it will be uploaded to different social media platforms. And my last question is I would like you to give us yeah, your general overview of you've told us that you have 98% of the surgeries you have carried out you have carried them laparoscopically. So I would like you to give us your general overview of your experience with laparoscopic surgery in Uganda, and then maybe the advice you would give to the young surgeons who would aspire to take that direction of laparoscopic surgery.
Yeah, thank you for that question. And I'm quite excited that I can see young people in training and young people in this generation trying to take up um, the path of modern technology. Because trust me and believe me, it is just a matter of time. You will not be able to work in any meaningful environment in the near future if you cannot have, if you don't have these skills on your belt. Um, I gave you an example of I've have a couple of colleagues who have, moved to Nairobi to practice, but they have failed because one of the requisitions now is that you must have minimal access skills, else you have to work in the rural area. Just simply because the patients are now aware of what is out there. They know their rights, they know what is good for them, and they will ask for these services. So for the young people, I think the earlier you try to train, the earlier you get to expose yourself, the better, because research has shown that young people generally take up these skills much easier than their older colleagues. It is easier to learn from first principles than to unlearn old tricks. So I really would say it is the way to go. Find a way of training. I don't know if you have any exposures in your university. That would be the first step. But what I've realized that even Makerere, a big institution, doesn't have any meaningful exposure to minimal access. Sometimes you have to do it your way. You have to find a training center and get yourself exposed. The more you train, the more you get better, and it improves your CV, it improves your confidence. You become a modern surgeon. You don't want to be opening up a belly in a patient, trying to look at the tubes, to take out an appendix, because most of, actually 70% of these ailments that bring patients to hospital are small ailments that can be fixed via minimal access. The bigger complex procedures are not the bulk of what brings patients to hospitals. So even if you are not able to do the complex surgeries out there, but at least you can be able to sort out 70% of the patient's problems, and you will be much more acceptable by the public. It is us to drive the institutions where we work to improve and to purchase these towers. As I said, these towers are not very expensive. They can be bought. It is only that there is limitation of skill to use them. So we need to come out of the comfort zone and try to push ourselves to train. That is what I would say for now, until the government one day comes on board to be able to make it cheaper for training. Thank you.
Well, thank you, Dr. Sai, for that insight. As we conclude, I would like to open the floor for any questions or comments. You raise your hand and you unmute. if there are any questions or comments, you can just raise your hand. Farhat, you can unmute and
All right. First of all, I would like to thank Dr. Spire for her presentation. But then my question would be like, if you have a chance, would you advise the government to train the surgeons based on the mass or the traditional conventional way, or both? Thank you.
Interesting question, Fahad. What I would say is that all over the world, the training is now minimal access all over the world. If I had a chance to talk to the government, I would tell them to do the right thing. The right thing is to train specialists and doctors on what will sell them beyond the confines of Uganda or Africa. As I mentioned earlier, when you move to the modern world, anatomy is now taught cadaver laparoscopically. They no longer do open cadaveric dissection. They do laparoscopic cadaveric dissections. And if you talk to the residents in those countries, we have met and interacted on several meetings and conferences. They've never seen an open appendectomy. They've never seen open cholecystectomy. They've never seen open hysterectomy. So you won't fit in. You won't fit in. Actually, some of them have to travel to Africa to be able to see the things done, which is a shame. So the right thing to do is to teach what is modern. Evidence-based medicine has it that minimal access is the way to go. I told you 99% of surgeries are done by minimal access. 99%. Personally, I've been able to do this in the last 2 years. I've barely opened up a few patients just because maybe they have very big myomas that I wouldn't take out laparoscopically. But 99% of my patients for the last 2 years have been minimal access. My hospital stay is between 24 hours to 48 hours. I rarely keep my patients on the ward. Most of them are daycare. I admit them on the same day. I discharge them in the evening. They go home happy. They return to work. And surgery should be a good experience to the patient. It should not be a punishment. So that is where we should go. That is what we should train upcoming surgeons to do, So yes, as much as we are talking about government, I really don't think that government is going to offer you this much. Government is still grappling with a few basic things. I think the effort should be individual. Most of the very good surgeons we have in the country have had an individual effort to improve themselves. Yeah, so that is basically what I think.
thank you for that wonderful submission. I'd like to know whether there are any other questions or comments that may arise from Doctor's presentation. You can raise your hand and unmute. If there are no more questions or comments, I would like to take this opportunity to conclude this meeting. I would like to thank Dr. Spire for sparing some time from his busy schedule and giving us this wonderful presentation. This presentation has been recorded and it will be watched by individuals who have not been able to attend, and it will be available on the internet. And I'd like to also thank our different members who have spared also their time, attend and listen to this wonderful presentation. We truly appreciate. Thank you, Okelo, Farhat, Abdul Karim, Chirumila, Mukashi, Divine, and everybody else. Have a wonderful evening. Thank you.
Thank you, everyone, for inviting me today. I'll be very glad if all of you take up minimum access skills as the future of the country. Thank you very much for this invitation and have a wonderful evening. Bye.